Enjoy these. Hi, everyone. Thanks for tuning in, and it's with a great pleasure and honor that I have Dr. Alpiner next to me here tonight to introduce some of the neurological disorders that we're going to start offering treatments for. And just a quick background, Dr. Alpiner was one of my attending physicians at Beaumont Hospital during my residency in the physical medicine and rehab department there.
Don't give me your.
Where part of what we do is help with the rehabilitation of patients who are suffering from various different neurological disorders. And I've always appreciated Dr. Alpiner's view on thinking outside the box, not just taking what's been written in textbooks, what's been taught for years, what the standard of care is, while standard of care treats the majority of patients and can help the majority of patients. There's always percentages and people that quote unquote fall through the cracks. And he's always challenged me to think beyond just what the textbooks necessarily are instructing. And you've had a big influence on me and the reason why I've gotten into regenerative medicine, whether you knew that or not. And I guess I'd like to turn it over to you to kind of talk about what your interests lie, where your specialty has taken you, and what you hope to accomplish by incorporating some of the regenerative therapies now for neurologic disease.
Thanks, appreciate it.
Yeah.
So, I've been practicing for a little while. Boarded in pediatrics, boarded in physical medicine rehab. And I think whenever you do pediatrics, you tend to always get toward a neuro slant. Get involved with more neurologic disorders. It seems more the dominant issue within children. But being adult, that tends to gravitate more towards traumatic brain injury and stroke, Parkinson's, neurodegenerative disorders. I remember during residency, literally was on the 0 to 3 year old floor in December and flipped over in January to the stroke floor in the adult at RIM. So it's almost that schism of the mind that lets you overlap larger thought processes. So thinking outside of the box is really more, to me, seeing, connecting dots and then putting lines through them instead of just random dots that don't connect. Mm-hmm. So one of the main things when I initially started that really got me more toward the neuro was when I saw that babies who were born with neurologic disorders and developed into disorders such as cerebral palsy. And then I was on the stroke floor. And I remember reading in one of the journals, clinics of perinatalology. This was years ago. And I remember looking at what the origin back then was inflammation of the brain, and we talk about free radicals and nitrites and all of these different pathways that lead to degenerative changes, either locally or more large scale within the brain. And literally, not long after that, when I went to the stroke floor, was the same pathophysiology for people who had a stroke, people who had traumatic brain injury. And you see these patterns of the brain that seem like, well, here's a kid with cerebral palsy, here's a person with a brain injury, here's a person with a stroke, here's this neurologic disorder, but there's such a dichotomy between the two. You don't cross the thing, but the patterns were the same. Mm-hmm. So it gets one to thinking, when you look back at just a basic cellular level, an insult to the brain. It doesn't have to be traumatic. It can be internal. It can be a stroke. It can be an infection. It could be degenerative. Alzheimer's disease, frontal temporal dementias, a lot of these different patterns that we see that we don't actually have an etiology. Someone who had encephalitis. And we're living in a time where you see so many more immune diseases that are triggered by the environment or triggered by infections. COVID for sure led into a series of neurologic patterns that were neuroinflammatory that could mimic any of the degenerative disorders. So over time, you start to see the same pattern again. So over the past probably 10 years plus, I've shifted a little more toward mild traumatic brain injury and concussion. because that was a huge population that was underserviced. Around 2004, before the NFL and all of the media hype about, concussion, I remember going to the hospital and saying to them, there's this population, these kids that are having more problems than I'm seeing with a moderate or severe head injury. And you look at the pathology, it's the same thing. It's this microinflammation post-trauma. And the symptoms were a little more agitating to the kids, or different patterns. And concussion, as a side note, there's like 6 subclassifications. It is not a one thing. It's a concussive syndrome. And it depends what pattern you fall into. But from, again, recognizing, or at least going to the pathology, comes back to the same thing. So recently, in the last 5 years, I got more into cellular medicine, my origin. So when you were a resident and I was pontificating on just academics, was that cellular mentality, right? Basic thing of someone's weak, why are they weak? Don't tell me they're just weak.
Right.
Where's the cellular problem of their weakness? Where is their issue coming from? Because you've got to dig deeper. I used to look at these pathways after someone had a head injury, and show slides with lecture after lecture I'd give. And I'd say, okay, here's the pathway, all these neurochemical things that are going off. This is happening in the mitochondria. This is happening in the cytoplasm. This is happening in the blah, 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 blah. And I'd blow right through that slide. But 5 years ago, I stopped doing that. I go, okay, listen to yourself. Cellular. It's cellular based. It's mitochondria. I don't want to get too bogged down into medical side of things. But the reality is a lot of different diseases begin through inflammation. Inflammation comes from where? That's a separate issue. How do you control that inflammation? So I got into a rabbit hole like everyone these days. Try to go on Netflix and you get into a rabbit hole of things I'm just watching. But it's very easy, if you don't understand something, to get into a rabbit hole, keep going down there and understanding less. So when you crawl out of the rabbit hole and you look down from a distance and you say something like, I just read an article in 2017 that there's emerging literature that people with Parkinson's disease and some of the structural abnormalities within the basal ganglia, which is the origin, and we see all these different things, actually has some connection with the gut. That the alpha-synuclein, which is the big name for the deposited abnormality within the basal ganglion, can originate in the gut, in the microbiome, and then transported through different circuitry or different signaling to the basal ganglia, to the brain. And then all of this data, and then there's another article, and another article over the next 3-4 years on the connection between the gut and the brain, which I always knew, the gut and the brain. I read an article. You said it. I remember the lectures where you said it. Yeah. And everyone looked at me like I was crazy.
Yes.
I remember there was a study in like the 40s, and it would only be in the 40s because it was in Russia. And they basically did something where they invaded the gut and they found certain areas within the brain or certain patterns that changed. That gut-brain connection, where I say they'll think with your gut. There's such crossover. The gut is your largest immune system. And if you think about that, a lot of the body's reactions neurologically is immune-based. Mm-hmm. Immune is nothing more than your body's trying to fight something. I don't care if it's internal or external or what's going on. Your body's got to form a reaction to it. It's got to form some way to treat it or help it. So this study went back years ago. I remember reading that. And I said, don't forget the gut. The gut is huge. And I didn't understand even when I was saying it what I meant by that. So what happened over time was more of an understanding that the body is a big immune response system. It can be local, it can be far away. For instance, your muscles release chemicals that these cytokines are actually anti-inflammatory. So when I tell someone to move, I now say you need to move, not because you're going to get stronger, but because you're actually, like I'll say with kids with concussion, you need to be active. You need to be active from the very beginning, because you need to release those chemicals within your muscles that will then cross the blood-brain barrier, that will go to the brain to decrease the inflammation, be pro-recovery. So again, all these different data, and I don't want to go in too tangential, but the point is, if you can understand the cellular mechanics of the body, how one cell talks to another, how one part of the body talks to another, how you can maneuver the nervous system in an advantageous instead of a disadvantageous position, then you can promote health. You can't always promote recovery. You can't always cure something. We know this. We live in the real world.
Especially neurologic disease.
Absolutely.
Yeah.
And a lot of times they'll say, well, once you've already had this process, then you can't help it. That I've never believed. You can make a difference on so many levels. You may not be able to recover completely, but you can work on their health span, which we talked about, right? There's lifespan. You don't want to live forever if you're going to live miserably.
Right. P&R, like our mentality is really function and quality of life.
Performance. And just be the best you can be at every stage. So from a neurologic standpoint, or neuro rehab, the earlier you start to have a symptom or can identify what that is, does it mean something, then the faster the better you have a chance to diminish the severity of it, right? But there's not a point, I do believe this, that I can't or you can't or, the people who want to make a difference in a different way can at least make something better. And that's not absolute. Obviously, there's points where, you can't.
So if we talk in neurologic disease, there's a lot of crossover, as you alluded to. If we just even kind of think about concussion as an example of many different neurologic diseases, you could explain just your approach on a more holistic view of, all right, you have this trauma to your brain, standard of care, we're going to use a stimulant, we're going to do something to help your brain fire more because you had this trauma in your brain. But the problem is more cellular than that. What kind of things do you look at that maybe are outside of the box as far as the gut-brain barrier goes, as far as diet goes, as far as exercise goes? Comment a little bit on some of those testing you do or some of those recommendations you might make.
Sure, good question. So I can tell you how I've transitioned over the past 5 years or so. So in concussion management itself basically is cocoon theory. It's been forever. No lights, don't go to school, don't do sports, shut down. I didn't believe that in 2000. I don't believe that now. The data is actually kind of moving in that position. Again, be as normal as you can, simulate your life, make certain that you keep routine. So I would, kind of get them back to sport very quickly. No competition, no contact, not injury, but just get back to your sport. Drills and skills, kind of get moving. Eat and drink, make sure you get back to school, control the environment a little bit, academic stresses, make sure their anxiety is controlled, work on sleep, say, do this, this, and this. Now, but that was forward thinking 10 years ago. Mm-hmm. And met with resistance and certain things. Your parents would say, well, that's not what I heard. I go, okay, that's not what your health can better.
We get that all the time too.
Like, okay, you could have heard that. Yep. I can tell you I have 4 legs and a tail. Don't. But, get it. And I understand. I'm a parent. I have 5 kids. I get where all this comes from. However, differently now. So now my recommendations are use melatonin, because melatonin actually opens up the lymphatics of your brain, which helps drain the garbage after the injury, which is very promoting of sleep, very promoting of recovery. So sleep regulation isn't just sleep regulation anymore. It's functional neurologic recovery to work on that cellular medicine. Mm-hmm. Creatine, which people use for strength, actually is pro-recovery in the brain, actually has a whole mechanism through a cascade of events that actually promotes recovery, decreases inflammation, has an antioxidant effect, promotes recovery. I'll use magnesium. I'll use the B's, vitamins, B2, B6. What I want to do is decrease the inflammatory component, which, not to get into the weeds, IL-6, interleukin-6 is a bad one. We don't want that one.
Mhm.
We want to him. There's very common, again, the same stuff in the gut. People who have irritable bowel syndrome, people who have a lot of gut problems, have very similar mechanisms to the brain. Heart very similar too. But again, it doesn't matter where, it's the same process, it's just someplace else. So I'll recommend melatonin more. I'll be much more progressive of getting them back to sport, to get the muscles firing and conditioning, to get those cytokines released, to cross the blood-brain barrier, to work on signals, to get the brain moving. I will allow them straight back into gaming. And I'm not a big fan of gaming because of the kind of occipital addiction that it can do. But gaming actually can promote crosstalk in the brain, neurochemical signals, which actually the kids will recover faster when I let them go back to gaming. I don't like social media, separate issue. However, it's candy food to the teenager. So I'll let them go back on digital if they can tolerate it, back on all electronic devices if they can tolerate it. You could make the argument that electronics and radio waves and electronic signaling is disruptive. And that's a separate argument to be gone over generations. And we're talking decades down the road. Short recovery is get them back into their normal flow. Try to promote neural recovery, neural signaling, visual spatial, visual motor, gaming. Using your phone is still crosstalk. It's still working on the brain's mechanisms. It's still allowing for visual, even though it's a visual narrow field. It's allowing for the brain to be comfortable, which promotes healing. What you don't want to do is you don't want to promote discourse in the brain. You don't want to have it fight itself.
Okay.
So you take a teenager and lock him in a cage, that brain's going to go crazy.
Mm-hmm.
It wants to seek out. And all it can seek out is pain. So,
and we see that a lot as the pain specialists. They come to us with pain, and the reality is it's a neurological source.
Yeah, self-imposed or not. And so diet is a big deal. You know, I say, I don't care if you eat crap food for the time you're with me, start eating higher protein, get some omega-3s in, keep hydrated, crucial, because the brain can react to diet very quickly. And if people don't believe that, I usually say, well, take a hot pepper, stick it in your mouth, take your heart rate before and after, and you tell me there's no effect food has on your body.
That's a great example.
So, I mean, the reality is in that short time, I want to decrease their recovery time, decrease their inflammatory processes that are going on. And so I have shifted from the cellular medicine approach. Mm-hmm. And, using, like I said, melatonin, creatinine. There are other types of pro-recovery agents to use. There are peptides.
I was hoping that was going to come up because that's a big part of the arsenal that we now have available to us. Somewhat limited with the new FDA challenges, but we're comfortable working around those challenges for the benefit of our patients.
Absolutely. Well, there are things that are peptide-like that work on the cellular membrane, the fat membrane, that work on reinforcing that structure. It's a funny name, drug called spermidine, which actually, if you trace it back, there may be an origin of how they used it initially, but we don't use the origin of it anymore, but it can come from a wheat germ, it can come from other things. And it is a pro-recovery agent.
So the peptides, we back up, it's a hot term right now. Essentially, it's a naturally occurring signal in your body that your body produces for one or multiple functions that is a shorter amino acid sequence than a hormone, but it's essentially the same thing as a hormone. It has a signaling effect in the body that if we can harness its purpose naturally, maybe augment the actual levels that are in your body, there's certain conditions where it can help the recovery process.
Absolutely. So let's jump a little bit to Parkinson's. Patients with Parkinson's disease, Parkinson's syndrome. Different types of them, some classifications, supranuclear palsy, not specifically Parkinson's. But if you look at the regimen that you would use, right? So a peptide, like you said, small amino acid can be, depending how it is. It is promoting the body's natural mechanism, right, to recover. Mm-hmm. So there's a cross reaction you can do between different things. A lot of patients with Parkinson's syndrome who are males have low testosterone. We know as we age that's normal, but it doesn't have to be acceptable.
Yep.
You know, if you believe that all the time, then you'd never use hormone replacement for HRT in women, or you wouldn't use it when men have a lower level. But part of health span comes with stabilizing certain hormones. But if you want to promote recovery and help with the brain, body, gut connection, if someone with Parkinson's disease has low testosterone, and at the same time you don't want to use a hormone, then a peptide can be used in place of the testosterone, as it signals the body how to produce certain patterns. And you can use both. You could use a little testosterone. You can use a different type of peptide, intranasal, oral, subcutaneous. Then you work into sleep regulation, and you work in exercise into that. You work on that sarcopenia, that muscular loss. There are some interesting data coming out on low-dose naltrexone with patients with Parkinson's syndrome. Because low-dose naltrexone, say, well, naltrexone, that's an opioid. We don't use an opioid. Look at the cellular mechanism. Look at the biophysiology, the patterns of pharmacologic intervention. It is an IL-6 inhibitor. Well, we don't want IL-6 to be firing all over the place. So let's create these pro-inflammatory and make it anti-inflammatory. The gut. So Brent mentioned before, that gut-brain connection with patients with Parkinson's syndrome. So let's regulate the gut a little differently, right? It's not a shotgun approach, it's a logical approach. We want to have one thing at the end of the day, a person more functional. They want to be better, we want them to be better.
Yep.
Let's work on those areas that are so neglected, that are thought of, well, no one does that. No, you don't do that. A lot of people use these treatments. If you look at the athletic literature and bodybuilders, they are better physicians than we are.
Yep.
And they know how to make what physiologic work for them in more healthy ways than you would think. Just pick up a magazine. It's very impressive, the logic that they use and the nutritional supplement, the timing of it, the peptides they use. And I learned a lot from it.
Yeah, no, it's opened my eyes to a lot of different theories and different therapies that during my time as training were frowned upon. And I can remember the lectures against HRT during my medical school with the HERS study that came out. That's all been very well debunked 20 plus some years later. But those are the exact same thought process we have in the orthopedic space, doing our regenerative orthopedics, that now we're extremely happy to have an expert in neurologic diseases. We get calls, and prior to Dr. Alpiner's decision to join with us, we've never been able to help those patients, and now we have a clinician who's got the expertise, he has the passion, and has the time to help our patients. So if it's something that you've heard tonight that you or a loved one might be able to benefit from, please feel free to give us a call. Michigan Center of Regenerative Medicine, 248-216-1008. www.regenerativemedicinemichigan.com is our website. Dr. Alpiner is taking patients. So if it's something you think you might be able to help with, we'd love to take a look and see if we can optimize your function.
Thank you. I appreciate it.
No, thanks for taking the time tonight to come. We try to keep our webinars the half hour or less. So hopefully you guys heard something tonight that you think would be helpful. We got a couple questions coming in. I think we might have a few minutes here for some of the questions. Dr. Santana, I don't know if you can read that upside down.
Let's see. Any peptides for breast cancer, HER2, POS cell membrane?
So that's not something I have a good knowledge about with the oncology space. I don't know if you feel comfortable answering that question or not.
No, so I stick within the neuro, and I do know that there are people throughout the country who will get more involved that oncologically, not to skirt the question, inflammatory or the metabolic state through the mTOR, the AMPK pathways. Again, not to get too much in the weeds, falls within that, but I'm not. That wouldn't be my expertise. I wouldn't want to.
If you want to shoot us an email, support@mcrfm.com. I have a referral I can help you out with that on that one. I think that's about as much time as we have. So thanks for tuning in. And again, if you have any questions or want to set up a consult, please give us a call. Thank you.